We're bringing you this talk with bonus. And without further ado, I'll hand over to Dr. Little, who's a clinical oncology registrar in London, and will be giving us a talk on careers and applications this evening. Thank you.
Thanks, Miranda. Welcome, everybody. Thanks for joining us this evening. So yeah, as Miranda said, I'm just going to be going through why you should do a career in oncology and a brief bit on the applications. I don't think my talk's going to be terribly long, but I'm happy to take questions if you just put them in the chat, and then we'll go through them all at the end. So in this session, we're going to go through what pathway to become an oncology specialist in the UK, the difference between medical versus clinical oncology, why you should choose a career in oncology, go through the pros and the cons, and tips for getting into oncology. So first of all, what is oncology? So it's the management of patients with non-hematological malignancies, and it's the non-surgical management. So that means hematology deal with leukemias and, for the main part, lymphomas, and oncologists deal with all other cancers. But the surgery is done by our surgical colleagues. So it's the specialist assessment and management of patients with cancer. And typically we discuss treatment options with patients, supervise their therapy, and manage any complications of the disease and the treatments that we give them. So the difference between medical versus clinical oncology. So we work very closely together. Medical oncologists deal with all systemic anti-cancer treatment, of which I think if you saw my talk on emergencies, we briefly went through, is all these things in the dark blue. So it's chemotherapy, antibodies, small molecules, immunotherapy, and hormones. Clinical oncology deal with all of that and radiotherapy as well, of which there's lots of different types now. I've just put some there. So external beam, stereotactic, which is the high dose to a very precise area. Brachytherapy, which you can put seeds inside the prostate and you can deliver radiotherapy via rods to the cervix. And radioactive isotopes. So an example of that is the radioiodine, which you use in thyroid cancer. So the main differences, so as we said already, medical oncologists do not give radiotherapy, but otherwise we both give all the same treatments. Clinical oncology training is therefore longer than medical oncology, so it's 5 years versus 4. Clinical oncology, we also do more exams because we have to do some special physics exams to do the radiotherapy. So we have in the oncology, we have clinical oncology, we have three exams. So we have 2 sets of written papers and then a practical that's similar to the PACES of MRCP, whereas medical oncology would just have 1 exam which is written. The clinical oncologists are members of the Royal College of Radiologists, and the medical oncologists are members of the Royal College of Physicians. And in terms of the patient load that we treat, actually radiotherapy cures a lot of cancers. So we have a lot of radical patients, so curative patients, whereas chemotherapy and all those systemic treatments on their own tend to not cure cancers. So lots of what medical oncologists do is palliative treatment, but they also give treatment before and after, say, surgery, which would be neoadjuvant or adjuvant. It's a very broad overview there. I've just done a very typical timetable of what the job involves as an oncologist. So I've done it for clin-onc, but it would be very similar for medical oncology. So as you can see, it's quite varied. We have a little bit of ward rounds potentially. We have space for admin and clinic preparation, then some clinics. In clin-onc, we would have where we go through all our radiotherapy plans in a meeting together with the other clinical oncologists. You look at it as a team. Then you'd have slots to do radiotherapy planning. You might have some more teaching. We're have lots of MDTs where we discuss all the new cancer patients, as well as patients that have progressed on their treatment, and we come up with a plan for what we should do next. And in that meeting would be the other members of the MDT, which I'll go through. Potentially another planning and admin session, another MDT for metastatic patients, perhaps another inpatient ward round, another clinic, and another clinic and another admin slot. So as you can see, it's quite outpatient based and different from other medical specialties and quite varied. In terms of medical oncology, it'd be very similar to that, but they'd have more clinics in the slots where the radiotherapy planning is. So in terms of the MDT, this is just a picture of everyone involved, but essentially it's a weekly meeting, and every single patient with a new diagnosis of cancer has to be discussed in that meeting. And you'd also potentially take patients to or cases to the meeting if you wanted opinions of the rest of the MDT. So the core members of the MDT would be the oncologist, and usually you'd have both medical and clinical oncologist in that meeting, a radiologist, a pathologist, and the surgeon. And then around that, you'd have potentially some other specialties as well, but they're the main core. So in terms of what we do in clinic, so we have a few different clinics. So potentially we have a new patient clinic. So this would be patients who should have already been told they've got a diagnosis of cancer, but it might have just been broken to them potentially by a CNS. So they come to clinic, you'd go through their diagnosis again, you'd assess how fit they were for treatment, decide on the management plan, which is usually already decided by the MDT, but you just confirm that you didn't need to change that based on the specific patient. You'd explain the plan to the patient. So if it was chemotherapy or radiotherapy or any of those other systemic treatments, you'd talk about the risks and benefits of the treatment, and you'd get them to sign a consent form. Then after they'd gone, you'd prescribe their treatment, write up your notes and do a letter. Patients that we have other clinics for patients that are already on treatment. So if that's a systemic anti-cancer treatment, we see them prior to each dose and we ask them how they found their previous dose. We assess their side effects from that, check the blood tests they will have had, and adjust the dose of the next cycle, it's called, if needed. So if they had intolerable side effects or if their bloods aren't right. Potentially in this clinic as well, they might have had a scan and we'd go through the results of the scan. If the scan showed things were worse, then we'd have to stop that treatment and talk about a new treatment. And as well as the side effects of our treatment, we'd also assess in that clinic the symptoms of their cancer itself, whether they've got any pain, and we can give them pain relief for that, or potentially consider palliative radiotherapy, or a variety of other things dependent on the symptoms. We also have on-treat clinics for radiotherapy patients. Their side effects tend to get worse as they progress through their treatment. So we usually see them weekly in the second half of their treatment if they're on a 6-week treatment, for instance. And again, we'd assess their side effects and give them medications or creams or whatever was needed to help with that. So stuff we do aside from clinic. So in terms of the clinics for radiotherapy, I think I showed a bit in my emergency talk, but every patient would have a radiotherapy planning scan, which is essentially a CT scan. And on every slice of that CT scan, you draw around the tumour and you draw around the organs that you don't want to treat. And that's called contouring. So that's a big part of what we do. Then that would go to physics and the radiotherapy planning radiographers, who would make a complex radiotherapy plan so that the highest dose goes to the tumour and safe doses go to those other organs. Once they're happy with the plan, it would come back to us as the clinical oncologist to check that plan and sign it off. So that's what we do in our radiotherapy sessions. And we also have to do a prescription for that. I showed on my timetable, we also have meetings for the radiotherapy. So once you've approved a plan, you'd also in the meeting take that to your other colleagues and check that they're happy with it as well. And then you have to review patients who are in the radiotherapy department who are unwell. In terms of the other cancer treatment, things in the so outside of clinic, you'd be prescribing their chemotherapy and again, reviewing patients who are unwell on the day unit. Some of our treatments require special funding, which you have to apply for. Then there's the inpatient. So this actually makes up a very small proportion of our workload. Only about 5% of oncology patients are on the ward. Most of our patients are well and as outpatients. But the inpatients, unfortunately, are our sickest patients and often our palliative dying patients. There's a lot of family discussions there. And I think it's important to note, if you do a job on the wards as an SHO on oncology, it's all can be quite depressing, whereas oncology, I would say, is definitely positive overall. So don't get dissuaded by the inpatient work, because the broad part of our job is actually outpatient. There's also the acute oncology unit, which should be in each hospital, and that's where patients on treatment can be reviewed in a day case unit. So again, they can come in with side effects and you can see them on the unit and assess them and hopefully send them home or admit them if they need to be admitted. So it's kind of like a triage area. Then again, other admin we'd have, so we'd have letters to sign off and check and emails as per other specialties. And usually there's lots of teaching opportunities for research and quality improvement projects as well. So why should you consider oncology? So I think it's a really fantastic career. There's loads of new oncology treatments and research happening all the time. So our job is constantly changing and there's constantly new things coming through. There's lots of opportunities for research. I'd say due to the nature of the work, most people that do oncology are really nice and supportive, and so it's a really nice team to work in. Also, you get to see your patients regularly in clinic. As I showed there, you see them before every treatment, and you usually see them from diagnosis either to cure or till they pass away. So you really get to build rapport and get to know your patients, which is quite a contrast to other specialties where you're just seeing them perhaps one-off. Cancer is becoming more and more common with our aging population, so we need more oncologists. And as I alluded to in my timetable, it's really varied, interesting job. So you have the clinics, the ward work, the chemotherapy prescribing, the radiotherapy, the day unit work, and the MDTs. It's a really nice, as I said, nice team, not just with the other oncologists, but also you really get to work with a wider MDT. We work very closely with our CNS nurse specialists, and the radiologists help us a lot with clin-onc, the pathologists, and it's definitely a team working environment. And I'd say it's suited to people if you potentially I really didn't like core medical training and found it quite stressful with sick people all the time and rushing from emergency to emergency. Oncology on the whole really isn't like that. It's mainly outpatient based and a different vibe, I'd say, from general medicine. So it depends what you like. There certainly are the emergencies if you do like that side. Currently, I'd consider this a pro. Maybe some people are con. We're not on the medical registrar rota, so we're totally separate. And our night shifts are usually on the phone from home. We normally do a 24-hour shift and we stay in hospital until 9, and then we have our nights from 9 till 9 on the phone usually, which I prefer to the nights in person. Also, certainly for the South trainees, there's for the first year, so as your ST3 year, there's a weekly teaching that all the South trainees go to in the country on a Friday. It's run at the ICR, and that teaches, because oncology is quite specialised, there's lots of new stuff to learn that you won't have come across before. That course teaches you that, and it's a good opportunity to meet your other colleagues and a really nice social day. The downsides, so it can be quite an emotional job. I think although it's not the main part, there certainly are quite a few family discussions, breaking bad news, which can take its toll. Usually they're the inpatients, but we do have that in clinic as well. And I think as well, it's quite an emotive, topic, and the NHS is really stressed at the minute, and often there are delays, and delays in cancer tend to make people angry, and miscommunication can lead to problems. I think it's a problem with every specialty at the minute, but perhaps particularly patients are more upset in the cancer setting. Usually for oncology, you're based in a tertiary hospital, but you would cover the more peripheral DGHs. So you might have lots of satellite clinics in different DGHs in a wider area, which potentially could be a downside. And I'd say for clinical oncology, we do have more exams than other specialties. I think hematology rival us as the same amount, but I think the pros outweigh the cons, I'd say. In terms of the training pathway in the UK, so first of all, you'd do 2 years of foundation training. Then you'd apply for internal medicine training. Now, actually, this is oncology, both medical and clinical oncology, is a Group 2 specialty. So that means you only need to do the 2 years of internal medical training, and then you can apply for your specialist oncology training. You don't need to go on and do the 3rd year, which is the year they're getting you to be a junior med reg, although you can do that if you wish and then apply after that. But even if you did do the 3 years, your specialist training wouldn't deduct years from that. So after IMT, whether you did the 2 or 3 years, you'd apply for your oncology training. So it's a separate application for medical and clinical oncology. Lots of people do apply to both and see which they get. Some people only apply to one. So the medical oncology is 4 years, as I said, ST3 to ST6, and the clinical oncology is 5 years. Lots of people go out of program during their specialist registrar training. So lots of people would come out of program to do an MD or a PhD. Pretty much all medical oncologists would do that, I would say. And lots of clinical oncologists do too, but it's not the majority. You can also do years out doing teaching, which is what I'm doing this year. And you can do fellow years where you do a year potentially abroad or in a specialist subject in the UK. So for clinical oncology, you can do special brachytherapy fellowships, for instance. It's really to get more experience in a specific treatment. And you can also do years out in management. You can basically apply to do whatever you want, but lots of people do take time out of program. And then following that, you would CCT, so complete your certificate of training and apply for a consultant job. Oh, one of the other differences, medical and clinical oncology, which I didn't say, is medical oncologists often, we all are involved with clinical trials, but medical oncologists often take the lead and often run a lot of trials, particularly phase 1 trials. So that is why the research degree is pretty much across the board. You don't have to have it, but lots do, particularly in London. This was just, I was looking at, so most specialties now are Group 1 specialties in IMT, and so do have to do that year as the med reg, but both medical and clinical oncology, along with these other quite random specialties, have got a way of being Group 2, so you don't have to do that 3rd year. So in terms of the application for oncology for the ST3, so it's basically very similar for the medical and clinical oncology, which is why people tend to apply to both, because it's not that much extra work. But basically the first thing, you have to have done 2 years of IMT or equivalent. And then you fill in this self-assessments, you fill in the application form, which would have a self-assessment score. And that has all these different things that it scores you on. So firstly is commitment to specialty, which is worth potentially 10 points. We'll go through that later. Then postgraduate qualifications, which is worth up to 4 points, which includes PhDs, MDs, masters, and potentially postgraduate diplomas or certificates. Additional achievements are up to 3 points. So if you've got an honours or a distinction in your initial medical degree or undergraduate degree, or if you've got some sort of international or national prize, particularly if that's related to oncology, you can get the full points. Having full MRCP gets you 8 points. So having completed part 1, 2, and PACES, but you'd have to have completed that before you started ST3. So it gets you points for this, but it's also, you wouldn't be able to start ST3 until you'd completed them. Presentations get up to 7 points, so that's including both poster and oral presentations, and you get the maximum points if you've got an oral presentation at a national conference as the first author. Publications get you up to 8 points. Again, first author, PubMed cited research gets you the most. Case report also gets you points. Teaching is up to 6 points, and the most points for that is if you've organised a teaching programme which you've regularly taught over 3 months with feedback. Having a PG cert or diploma gives you points. Quality improvement project, 5 points if you've completed 2 cycles. And then there's a thing for leadership, so having a national regional leadership role for 6 months that's made an impact. Now, I think these are the same for most medical specialties. I've put in pink there the ones that I think I would focus on. Some are just totally unachievable, like unless you're very lucky, I wouldn't worry about getting a PhD. or distinction in your medical degree, or I'd really focus on the things that are easy to get and try and do those. So I think what is potentially achievable is certainly a poster at a national conference, which you can be first author on, and doing some teaching, potentially doing the PG cert, although that is lots of extra work as well. Actually, if you can just organise some teaching for the foundation years during your IMT and do that regularly over 3 months and have feedback, that would get you the most points. And potentially you could be clever and do your quality improvement project, do the 2 cycles and use that as your presentation at a conference. So I think my advice would be to look at the application form in advance and pick out a few things that are achievable to do in your IMT and try and do them. Wouldn't worry too much if you don't have lots of these. I didn't have all of them by any means, but try and get the easy points if you can. So following that, and you'd have to upload evidence of all those things, so they'll know if you can't lie. So following that, they'd long list people that meet the eligibility criteria. They'd either interview everybody, or if they had too many applicants, they'd shortlist those for interview, and then you'd be invited for interview. So the interviews are both all on Teams now, they're all online. This is the medical oncology interview. So it's 4 questions. One's on a clinical scenario, one's on professionalism and governance, and one's on academic and research, and one's on suitability and commitment. And you've got 2 interviewers for each, and each gives you a score out of 5. And then basically they'll decide based on the score whether you're considered for offers or not. In terms of the clinical oncology, again, it's really similar, but this time you have 2 clinical questions, then an ethical, communication and clinical governance question, and then 2 questions based on your portfolio and experience so far. So that would be asking you about everything you'd put into your self-assessed questionnaire. So your posters and publications and everything like that. I think the main difference is that medical oncology has that extra question about research, and that's because, as I said, they tend to lead the way with research. In terms of preparation for interviews, I'd recommend this book, which has been going for quite a while. It's not specific for oncology, but it has basically lists all the standard questions that you can expect in that. So in the portfolio and experience, or in the suitability and commitment in the medical oncology. So they'll definitely ask you, why do you want to do oncology? Why do you want to do medical rather than clinical oncology? What are your best qualities? What are your worst qualities? That sort of thing. This book has good things you can say for all those general questions. It won't be specific for oncology, but it's got really good tips in there. It also has tips in there on the ethical station and the governance station, which tend to be, again, quite generic across the board. Potentially a station on capacity, consent, DNAR could come up. The clinical scenarios tend to be quite straightforward, but I'd go through oncology emergencies, make sure you know the management for those, and the acute oncology stuff. So, what would you do with a patient that's breathless, for instance? And so in a patient with known lung cancer, for instance, you might want to think about just general things such as they might have pneumonia, they might have a blood clot, they might then think about more cancer specific, so they might have SVCO and that sort of thing. But they like you to start general, so don't go straight in with the oncology emergency, but go in with, I'd want to check the usual things, so as for any medical patient. I think the main things is actually to remember that a lot of how you come across is not on what you say, but on how you say it. So I'd practice with a friend or a family member, talking out loud, sounding confident and having good body language, because I think that is actually a huge part of how you come across. So the commitment to specialty is part of both, I think, the self-assessment form and potentially could be a question you're asked. I think you can include basically anything in this, but things that I would potentially do so that you could answer this question in advance is try and get an oncology job in your IMT. If you can't get an oncology job, try and get a palliative care or a haematology job, because palliative care is very relevant to oncology, and haematology, lots of them, the haematology malignancies would still give you experience of chemotherapy as well. If you can't get any of those, then do a taster day in oncology and come and see us, come and sit in on a clinic. In terms of saying why you want to do medical versus clinical oncology, sit in on a medical oncology clinic, sit in on a clinical radiotherapy clinic, come to some radiotherapy planning and see what that's like, so you can talk about how you've seen both and you preferred one to the other. In terms of if you want to do clinical oncology, you can actually ask us to have a go at doing some radiotherapy planning. It won't be what we use for the patient, but if you have a go, we can take a print screen and you could put that in your portfolio as evidence. Again, for the commitment, try and do your projects, your posters or your quality improvement projects in a subject relevant for oncology, and then present that at an oncology conference. Even if you can't get a poster as an oncology conference, just attending oncology conferences. So the Marsden run lots of small conferences on just topics such as pain relief in cancer, for instance, that you can attend. They're not very expensive. And the ICR run one. There's loads of different conferences out there that you can attend even if you're not presenting, and that shows commitment to specialty. You should be able to get study budget for those as well. I'd say communication is a big part of oncology. So if you go to an advanced communication skills workshop, and I think the MPS runs some of those for free, so you can attend those. And the European Society of Oncology also run a course called Oncology Basics for Beginners. If I just have a Google as to what courses or workshops are out there on oncology and attend it, get a certificate, and you can use that for your commitment to specialty. I'm sure there are lots of other things, but they were my ideas for that question, because I think it's a bit hard to know what to put in that. And that was really my overview. This is the link for the feedback. It's been quite quick, so let's have a look at any questions.